Elgon are able to go to their facility and they're able to have an intervention. We had a theatre that was already finished in another sub-county, Tongaren, and again through working with the partners, the Member of Parliament, and a few partners that had worked on that theatre, we were able to get it opened, and now those mothers don't have to travel a very long distance
to get services,
to get the services. And then we got the privilege to have Her Excellency the First Lady consider us to be one of the counties that she donated some equipment, and through the CURE program. And it is equipment that will go towards some of these facilities to just try and put them in a better space to serve.
Thank you so much for that. I know, you know, this is going a long way in even speaking to other counties as well, because I know there is a lot of effort and sacrifice that goes into making this happen. And we'll be coming back to that just to talk more about what has worked for you as part of your strategy, so that we can be able to learn more from even the vision that you have going forward. But allow me also just now, allow us to have our guest. We were expecting Milcah Akalah from AMREF. She's already in studio. Just if you can walk on set just to join us. She heads specialized camps at AMREF, working a lot in terms of making sure that they take their services to the different counties. Just create some room for her. Thank you so much for that. Thank you so much, Milcah, for joining us this morning. Just there was a very important camp that you took all the way to Bungoma County, where Caroline Wangamati comes from, and we were just talking about, you know, today fistula, and we were preparing ourselves for that very important conversation. But before that, she was telling me, you know, what she has been able to achieve in the county of Bungoma. And before we get into the conversation of fistula, I will allow you to just finish up on the vision that we have, you know, for the people of Bungoma later on. But thank you so much for joining us, Milcah. Probably just a word of hello to our viewer.
Thank you, everyone. Welcome to today's show.
All right.
My name is Milcah Akalah. I work at AMREF Health Africa. I coordinate the Kenya Specialist Outreach Project.
All right. Thank you so much, Milcah, for joining us. And let me allow you quickly to finish up on, you know, going forward. You've talked to us about some of the things that you've been able to do to influence the health sector in Bungoma County. And I want to understand why health, and why are you so passionate about maternal health, to be specific? Where did that dream and passion come from?
Okay, thanks, Safina. That's a very interesting question. In terms of my training, my education, I'm actually a Bachelor of Commerce. I'm a finance girl. So this is very odd because...
Yeah, it's kind of clashing with...
It is a clash, but I think health is something that I've always been interested in. And it's one of those things that... I'm not sure what to say. Let's just say it is a passion, but also my own personal story. When I needed to have children, I went through quite a number of complications. And that put me in a very good position to be able to articulate some of these issues. I had difficult pregnancies, you know, a bit of what we talk about with the mothers, a bit of the bleeding. All my children were born premature, so it is something that I understand very well in terms of having the skilled care to look after such children. But also because of the nature of my pregnancies, I needed to be in a facility, otherwise there's a good chance myself or my children may not have lived. So it comes so naturally to be able to advocate for the mothers in Bungoma, because what I always say is that there's nothing very special about me that made me have access to the best. I should be able to fight in my space to get them to have as close to what I had as possible, or even better. And the fact that health is devolved is a great thing for me, in the fact that for once as a county, we are able to look at the different regions, the different sub-counties, and tell ourselves, you know, Sirisia sub-county is having a burden. What can we do about it? Mount Elgon sub-county is having a burden. What can we do about it? You know, Bumula sub-county. So you're able to take a population and try to do something that truly, truly will help them in matters health. And also, if you were to think about it, when you're healthy like you and I are sitting here today, we're able to work, we're able to do so much. You cannot discuss wealth creation, you cannot discuss anything else with a population that's not well. You have to start, health is wealth. You have to start from there. So it's a natural starting point for me. And mothers are the naturals. So you have to start from there. Let the governor think about, you know, the other big projects. But I think for me, I have to start with are our people healthy enough? Are our children healthy enough? Are our mothers healthy enough? Our elderly people? It has to be the starting point. So that's what
Earlier on, I also told you that I want to understand what has worked for you. What is that strategy that personally you have implemented to make sure that you have all the networks and the resources that you need? Because it's not easy. You may have the opportunity and the platform, but it's not easy to make things happen on the ground. What has worked for you?
So one of the things that I felt worked for me is that, one is that have a genuine interest in truly understanding what is going on with your particular constituents. And that means truly being on the ground, you know, like take time and walk in your facilities, sit around with people and talk to them. And I think when it comes to the space of health, that is something I've done very successfully. There isn't a level 4 facility in Bungoma that I have not visited and opened all the different doors and understood, do they have a laundry, do they not? Is the theater working? Is it not? Do they have? So that's one. And that will inform the strategy that you can take in terms of solving the problem, because you need to have a baseline. You need to be able to look, what do we have, what don't we have? What is it that you are underestimating? What is it that you are probably assuming we have and we don't have? Then the second one that works very well, especially again in the space of health, for my case, is working with the partners that are on the ground. The health sector in Africa generally, and I remember I think it was Governor Oparanya speaking at the Devolution Conference saying, in health, you will not only depend on the disbursement that's coming in from the national government. You have to embrace the partners that are working within your county and be able to work together towards achieving that strategy. The reason we've looked very successful in what we've done, and we've been able to do this, the second medical camp that we had, and that 2 more before the close of the year, is because we've embraced the partners. We have wonderful people like AMREF here that will literally, if you have a passion in the vision and you invite them over, they are willing to come in and truly support whatever it is that you want to do. In this case, it was fistula, and they're able to come in. We have so many other partners on the ground. We have money, we have AMPATH, that anytime we're doing an activity matters health, they are so willing to actually come on board and support, and it's an amazing thing.
Wow.
So you have to rally these people and bring them together.
All right.
Then you also must have a relationship with the county health team. One of the things I said is that as an office, we don't work in isolation. We work very closely together with the CC's office and the county health management team for Bungoma County. So we never do anything just as an office outside. We make sure that we've integrated ourselves very closely and we work as a team together, because you're not looking for a success just in itself, you know, like for our office. We're looking to improve the lives of the people of Bungoma County, and all the stakeholders have to come on board. And so we work very closely with our CC, Dr. Anthony Walela, who's a good friend of mine from a long time ago. The CHMT team are wonderful people, and they truly want to improve the lives. And then we bring on the advocacy from our office and the partners, and it's a complete team.
So you sort of like just make sure that you work with the whole network and the entire team to get to understand the unique needs and how you can come in and what you can be able to assist in.
Absolutely.
And I will be getting back to more of what you're doing and more of what you're planning in Bungoma, but allow me now, you know, begin the conversation on our fistula. That is what we're focusing on this morning. This is Women at the Forefront. Usually here we just focus on issues affecting women and trying to bring up a better generation of women, looking at some of the solutions that we can be able to come up with such conversations going forward to make sure that we form, you know, a basis for a solution for these issues. And Milcah, recently there was that camp that, courtesy of AMREF, you worked together with Bungoma County to make sure that there was a fistula camp that was done there. Tell us a bit about the highlights of that event. What are some of the things that, you know, came out of that? You know, a sort of a report that you can give us about that.
Thank you. First of all, I want to make people understand what a fistula is. A fistula is an abnormal opening or an abnormal communication between the uterus and the bladder, or the uterus and the rectum. These 3 organs are so close to each other anatomically. That is the way we are made normally. So in case there's an accident or there's a problem during the process of labor and delivery, there's usually an abnormal connection between either the bladder and the rectum, or the bladder and the uterus, and or the rectum and the uterus. In this case, you'll find that if a woman has this kind of problem, she will leak stool if the trauma happened to the rectum, or urine uncontrollably and without her knowledge. She can't feel pressed to go to the washrooms, or she can't feel like now she needs to go to the toilet. So either the urine or stool flows uncontrollably and against her will. So this is a problem that is common among our women, although it's a problem that people don't come out openly to talk about.
All right.
Even the people who are affected are not willing to come out openly and say that they actually have this problem.
All right.
So this woman will continue suffering. She will isolate herself. She will not participate in any economic or social events. Hence, it affects her economically. It affects her socially. She can't join any social events, even as simple as a church function or even attending funerals or any other women activities that would be happening around her. So this really puts her off. It puts her off socially, it puts her off economically, and she literally just lives her own small, miserable life. So it was through her initiative that Bungoma County was highlighted as one of the counties that has quite a number of these cases who are actually hidden. But she, due to her closeness with her people, she got to get information that there are women out there who need this assistance. So she approached AMREF and asked if we could support her to address this problem. And this is part of the work that we usually do as an organization and as a project. So we actually accepted to assist the county. We had a fundraising partner who had given us some money with a specific interest for fistula repairs. So we partnered with the county and identified a suitable health facility, that is Webuye County Hospital, where we could conduct this activity. So it was a very successful event. We went to Webuye. We conducted a training for the host healthcare workers so that they can continue identifying these clients in future and get them helped. Usually we have a team of specialists whom we work with in different counties that we work. So this was just one of our activities that we conduct usually. We went to Webuye County Hospital. We had 2 specialist surgeons. We had 2 fistula nurses who supported the health facility to conduct this activity.
How was the turn-up like? How many people came up? And you say, you know, the event was successful. Did you have, like, tell us a bit about how the women in Bungoma County turned up? What was the numbers or the figures of people who came for consultation even?
Okay, usually this event is kind of integrated with other events, other very important services to women, cancer screening.
Okay.
During the screening for fistula, we check the internal birth canal of a woman. So at this juncture, we use the same opportunity to screen for cervical cancer. Okay. We screened over 200 mothers or 200 women for cervical cancer. Actually, to be specific enough, 219, out of which 8 clients had precancer lesions. A woman who has a precancer lesion is a woman who is starting to develop cervical cancer. There are a few whose own body mechanism will be able to work out naturally and clear the infection. But a high number of women progress into cancer as a disease. Okay,
so that was 8 out of 200?
219.
219.
It was an opportunity to identify this mother at an early stage, and all the 8 got treated. In the process, we also identified 2 others who had. There's a time where we can treat these mothers by freezing the cancer lesion, but others have already had the disease into a more advanced stage and require surgery. So they also benefited from surgical interventions. Therefore, they will not suffer the consequences of cervical cancer as they would.
All right.
Out of these women that we screened, 32 were operated. The two who had early cancer, and this is now solved. They will not have the progression of the disease again.
Wow.
And then the others had either fistula. The fistula, there is VVF and RVF. RVF is when the stool is leaking, and VVF is when the urine is leaking. Okay. So we managed to address quite a number of women with this kind of problem. Others encountered very serious tears during their childbirth, and this also makes them unable to control their stool their stool when they feel pressed. We had a small girl of about 19 years who thought that this is what happens to mothers when they give birth.
And that speaks to the fact that, you know, there is a lot of lack of awareness in this issue, a lot of misconceptions about fistula. They've said it is a curse. They've said people tend to associate it with a lot of things. I don't know if, you know, before even the camp took place, I'm sure you went, you know, trying to be part of even the awareness, finding out the numbers of women. She has said that Bungoma County is actually among the counties that are leading in numbers of these cases. What do you think, you know, people, where are the people in terms of awareness about fistula? What are they saying fistula is? Do they even know?
My own take, and my own take is that I don't think we knew, and I want to be honest enough, Serfine, and tell you, I didn't know about fistula until the day I was in Mount Elgon we were actually going for a beekeeping training, and our teacher delayed. So the mamas decided that we have a conversation, and the sub-county chair lady, an amazing woman, stood up and told me, Mama, we have problems here, and since you're our mother, we want to tell you. And they talked about fistula. And I remember that when we were doing the induction, because AMREF came on board during our induction, they did mention that they do specialist camps. They mentioned orthopedic camps and fistula camps. So what I did is I actually stepped out of the meeting when we were done, and I called AMREF. So I kept thinking, I'm supposedly somebody who is very passionate about health, supposedly well-educated, supposedly very exposed, and I didn't know about fistula.
What about
Think about the other person.
Yeah, in a remote place.
Absolutely. So even the community, the reason they ostracize these women is pure lack of knowledge.
Exactly.
You know, a woman is sitting in a place and she's reeking of a smell of urine. Yeah. And automatically the community says you're not a clean woman, you don't even wash yourself properly. So you're actually, it's ignorance that speaks to us. So we need to raise the awareness and tell our people that it is not her fault, but also it is something we can do something about, and it is not dependent on her financial position. There are great benefactors, really, I mean, God sent people like AMREF and their donors who are able to help us. And the reason fistula is called a poor person's disease is because if you had a fistula today, 2-3 days you'll be like, something is wrong with me, and you'll visit a doctor and you'll be able to get some treatment. But this poor person doesn't even have the 50 shillings to buy food for the family. So when is this woman going to start thinking, one, that I even have a problem that needs to be attended to? The little girl that Milcah is talking about had a first baby and developed the fistula at that point. She still had to live with a husband and have to, you know, go through whatever she went through to now get a second baby. And thank God she had a cesarean section for the second baby. So when we asked her, didn't you know you have a problem? And she said, I just thought when you give birth, these are the attendant problems. And I told her, no, we've all given birth, as you see us, and we don't have this problem. And you just realize, and especially with teenage pregnancies that are happening, a lot of these kids, they may be having obstructed labor because anatomically they may not be very ready to have children. They're likely to be people that are actually suffering with fistula. Yesterday I was called and told in Mount Elgon I have a 12-year-old that has a fistula. I was going to tell you about that. And you just need to find these people, but also educate the community and tell them, don't shun them. So on the day of the closing of the camp, when I spoke to the public, I told them, if you're sitting with a woman who is smelling of urine or smelling of, you know, stool, instead of laughing at her and shunning her, encourage her to just find some little money and come to this facility, and she will be screened, and then we'll refer her to a place where she can get the treatment. So it's really advocacy, spreading the knowledge and telling people how this disease comes about.
Right.
So that
as part of awareness, Milcah, what are some of the risk factors? Early pregnancy is one of them. It comes out very clearly from what you're sharing this morning. But then tell us more about what is it that would add on to, you know, somebody to be at risk of getting fistula, because we are trying to prevent these cases as much as we can. Tell us a bit about that.
Thank you. Actually, the main prevention, or the main thing that we need to do about preventing fistula is encouraging our women to deliver under skilled attendance. By this, I mean that every pregnant woman should deliver in a health facility, get attended to by our qualified personnel, so that anything that could be coming up can be addressed appropriately. women should also realize that surgical deliveries or cesarean sections are not a curse, are not bad. It is to save a life. Sometimes the baby is too big to pass through this woman's birth canal. Sometimes the woman is so small, even for a small baby to pass through. Sometimes the position of the baby is not appropriate for the baby to be born normally. So women out there should realize that at the end of pregnancy, we expect a healthy mother and a healthy baby. They should not struggle like they have to deliver normally by the natural method when things are not working well for them. Even a surgical delivery is fine as long as she is healthy, she has a healthy baby. So my biggest message to the general public is that every man should ensure that his woman delivers at a health facility. And every pregnant woman at the earliest opportune time should get to a health facility when they realize they are pregnant. And then our mothers should also stop going to the hospital when it's so late. Some of them labor at home for so long. The labor is prolonged. Yeah. There is obstruction, and it is during that process that they develop a fistula. Because as the pressure, the baby's head continues pressing either on the rectum or on the bladder, that pressure cuts off blood supply. And with the continuous cut of blood supply, the tissues at that area die. And when the tissues die, that is when we get a hole or an abnormal opening between the bladder and the uterus. And I also want to urge communities that encourage early marriages of girls. This should be really discouraged, because the younger the girl, the higher the risks. Other traditional or cultural practices like FGM also contribute to high incidences of fistula, because this woman is so tight and may not be able to open up for the natural process of birth to take place. So it's important that we improve, or rather scale up our reproductive health services to be able to completely stop this fistula problem. It is really sad that in Kenya in 2018 we still have women who are getting fistula during childbirth. It's really
I was looking at some numbers. 3 to 4 out of 1,000 deliveries, women go through this. It's really unfortunate that even today, with all the technology and the knowledge that we as a country pride in, we still have these cases. It's really unfortunate. But then again, just trying to create the level of awareness, I think is a big way to go. I think is a step in the right direction. Let's talk about, the treatment. Most of these patients would complain that they only find out after they've gone home. Is there a way of even the caregivers and the professionals at the hospital, the delivery rooms, is there a way of them noticing this and even helping out at that stage?
Yes, at the time of delivery, when the baby comes out, the placenta comes out, the health provider, the skilled birth attendant examines the mother. And they are supposed to examine the birth canal all the way up. So that they get to know if there is any leakage. And even after that, we encourage that these mothers stay under skilled observation for at least 24 to 48 hours. During this period, we encourage a lot that the mother passes urine, because that also helps in reducing in the size of the uterus, and therefore to stop any bleeding that would occur. So during this period, if there is close monitoring, if there is good observation, any problem would be detected. And currently we have a package of postnatal care. This postnatal care package is also a period where the health worker and the client should interact very closely and detect any problem that could have occurred during childbirth. We encourage that after birth, every woman should be seen, either at the health facility or the health worker goes to the woman at least after 24 hours, after 2 weeks, after 6 weeks, just to confirm that things are working well, to confirm that this woman is not bleeding, to confirm that this woman is not getting an infection, to confirm that the baby is well. The cord is clean, the cord stamp is clean, to confirm that the baby is breastfeeding well, the breasts are not swelling, just to ensure that all is well. So if we can embrace and really take up these services, then we can reduce the number of cases that go unnoticed. we can also be able to capture these mothers in good time and attend to them. Most of the clients that we attend to have stayed with this problem for so long.
So many years.
Unacceptably
For so many
long.
years, yeah.
And it's quite a sad situation for them. They have really, you can imagine how many years they have lost. How can they make up for that? How can they even get accepted back into the community? This is the woman who has been smelling urine around. When she starts a small burger business, who will
come
even...
and buy? Marriages have been broken because of
exactly,
this. And a lot of stigma has been associated to women who go through this. I don't know.
Just to add on what Milcah was saying, one of the reasons why, again, Linda Mama is so powerful is because Linda Mama pays for 4 antenatal visits. It pays for any complications while you're pregnant. It pays for the delivery, and it pays for 4 postnatal visits. So this mother, to get checked the way Milcah is talking about, she shouldn't have to pay. It is part of the Linda Mama package. So if every single expectant mother in this country could actually get on Linda Mama, then they're not worried that I'll have to look for 100 shillings to pay for me to be examined. She'll be able to be examined on this package of Linda Mama. And that's why, as far as I'm concerned, Linda Mama would really help us take care of a lot of these reproductive issues that come when a mother is pregnant. So just adding a voice to what she was saying.
All right. I want to ask this question to the both of you. Just let us look at the dynamics, because yes, you are advocating for every woman to at least be in the presence of a professional while delivering as part of, you know, the solution to this. But is it practical? I was looking at some numbers as well, and they say that there is you know, a woman dies every minute because of pregnancy-related complications, and 95% of these women are in Africa.
Sure.
I want us to look at the dynamics of Africa, and even just our country, Kenya, our health care systems, the hospitals that we have, the numbers that we have, the equipments that we have. Are we really prepared to ensure that every woman can be attended to and can get all these services that you're advocating? Are we really prepared for that era? Are we there? I want a cocktail of both your responses on this, yeah? Because we're trying to look at the realistic part of it. Is it possible that we can actually get the women to be attended to and to get all the services that they need? Even that woman in the remotest part of this country who has very little knowledge about what we're even talking about today. Are we there as a continent? Let me start with you, Milcah.
Okay, yes, we are there. And I'm imagining that if all of us hold hands, it can actually happen. And it's important to note that most reproductive health issues cannot be addressed by health alone, health as a department alone.
Okay.
We need to have a multisectoral approach so that we can look at the different factors that are delaying this mother from getting to the health facility. The first thing, if this woman attends antenatal care properly, she will be able to get to know that she needs to deliver in a health facility. She'll be taught on the signs of labor. She'll be taught on danger signs during pregnancy, during delivery and after delivery. Therefore, in case she encounters any of these, she'll be able to seek medical attention in good time. So information, very crucial.
Yes.
This should start at as early as possible in pregnancy to everyone. Actually, it should start even before the mother conceives. In this country, we don't have a good exercise of preconception care. Even before a woman conceives, she's supposed to receive some care. She's supposed to receive some supplements. Some of the issues that we see even at birth or congenital problems can be easily addressed by very simple and very cheap measures. For example, the spina bifida, the complication that babies are born with, it is simply folic. Folic is a very cheap drug. The only unfortunate thing is that our women start clinic very late. So by the time they are starting to take these supplements, this baby has already been formed. If she had low folic in her, the damage is already done. She needs to start this supplementation very early. Once this mother are successful, once we achieve a successful antenatal coverage, then we shall be moving towards delivery. Delivery is a procedure that can be conducted in a very low facility, as low as a dispensary. So all we need is to have at least most of our our country is well covered by public health facilities.
Yes, that's true.
I know they are not equitably distributed, but at least there is some health facility. And if this woman is aware that I am approaching my due date, I am approaching the signs that I was told could lead to labor, my water has come out, I need to get to a health facility. The nomadic counties have what we call the shelters where mothers come when they are approaching their dates of delivery. If we can embrace all this, we can make a big difference. And then if our women can also just be empowered with information, women, men, everyone in community, because even this man has a very big role to contribute towards the success of this delivery. Maybe he's the one who provides bus fare to get to the facility. At the health facility, we also develop birth plans. When they are doing antenatal care, at whatever level, even at dispensary level, we developed individual birth plans with the clients. We ask them where they would want to get to deliver. Like if it's a mother that we anticipate a problem, then we encourage that she goes to a higher level facility. For example, if she has had a cesarean section delivery in her previous birth, then she is at risk of we can't allow her to deliver in a dispensary or a health center. This is a mother that we would want to start counseling well in advance so that she gets prepared. She gets an open mind that, yes, I may be lucky to deliver normal, but I can still go back for cesarean section. But it is for the sake of my baby and myself. I get a living baby, a living normal baby, and I'm healthy myself. If we empower our women with this information, if we empower our men with this information, if we empower our mothers-in-law with this information, because they are also a very important contributing factor.
I can't believe you went there, but it's important.
They are a very important,
it's really important
team that we always forget. They are actually very significant in the success of these stories, because a mother-in-law will tell the daughter-in-law that I delivered your husband here, you will deliver here. In some cases, they are very influential and their decision is final. So if this woman, the woman who is pregnant herself is not empowered, especially those very young ones, then it gets really difficult for them to make their own decision. So empowering women, encouraging girls to go to school is also another very important approach, because one, it will delay their pregnancy. Two, it will make them have some power to make a decision. It will make them have maybe some little source of income, because during those clinics, we also encourage them to have some small saving, just in case. Even like in Nairobi, labor begins at night. You don't have a means to get to the hospital. At least if you have some 1,000 bob, you can call a taxi,
you can call
and they'll take you to the hospital. Even at in the rural setups, we also need to work with different sectors like roads. Sometimes we need to really refer a client very urgently. The roads are so bad. It has rained. We are getting stuck. This is how we lose these mothers. And then we need to, of course, encourage our government to ensure that all levels of facilities are well equipped. There are very simple basic measures like mothers who come in with very high blood pressure. This is the leading cause of maternal deaths is bleeding. This can actually be treated or handled, or at least that you begin some management at dispensary level, at health center level, and then we refer this mother for further observation. Like if she needs surgery, if she needs blood transfusion, we need to get her to that level of a facility. If we have magnesium sulfate in a dispensary, if this mother is coming in with very high blood pressure, the second cause of maternal mortality, we shall be able to give this woman some medication as we refer her to a higher level facility. So I would encourage that a lot of investments should be done at the low level facilities, because these are the facilities that encounter these women initially. And the way they handle them will actually affect the outcome.
All right. It's the little efforts that count from what you're sharing with us.
Exactly.
Every sector is important.
Every sector
Every little effort is important.
And the client themselves, the family, the client should be able to tell that something is not right. For example, if they are having a lot of headaches, if they are not seeing well, those are signs that something is wrong. Their pressure is going high. If they go home and they are bleeding, even the husband should be able to tell that something is not wrong. Yeah, he should be able and available to get the woman to the health
I'm coming back to
facility.
you to finish up on the aftercare. After the patient has gotten the surgery, what is the aftercare that is needed? But yeah, I wanted a cocktail of how do we reduce the
So
95%?
She's
She's
covered
touched
like
on
most
so
of
many
it,
things, yeah?
But I'll just say I totally agree with what Milcah has said. There's a report that was released in February. It says it's the first ever report done in Kenya. It's a confidential inquiry into mother's death. It's a very good report for you to have a look at some point.
Okay.
And it said 9 out of 10 maternal mortalities that we encounter can be prevented. And they talked about some of the causes. I liked what she talked about. 2 out of 5 mothers in this country are dying from PPH, the hemorrhage. So if we had sufficient blood, Kenya has only 30% sufficiency in terms of blood. We all need to get out there and donate blood, those people who can. And you go through a screening process and we donate blood, because you can have the best theater, the most qualified medical personnel. If a mother has bled and she needs blood, you will still lose her if you're not able to give her blood. They talked about a very important thing, which is most of the deaths, I don't remember the percentage, are happening either after work hours or they're happening during the night, or sorry, so that's after work hours or on weekends. So one of the little things that we all need to do for our facilities is try to get our facilities to operate 24 hours. For reasons which I don't want to go into, I'm told most of us give birth at night. Or some doctor joked and made a very interesting joke about it. But anyway, so we need our facilities to operate at night, because if we operated at night, we're likely to attend to these mothers, you know, when they need the attention. But if a mother has to stay back because her dispensary is closed. Actually, one person told me that my mothers in this region only get sick between 9 and 5. So he was making a joke to say, we are not allowed to be sick at any other time. So again, if we could just have our facilities work outside of those hours, it would really help. There are these great people called community health volunteers. These are people that we need to empower, all of us in our counties, in whichever way we can. Because these people sit within the community, are recruited by the community, and are trusted by the community. If we can send this message to them, they'll be able to bring our mothers to the facility. Like Milcah said, one of the things I'm really trying to advocate for is I want our mothers to come in for the 4th ANC visit. Most of them do the first one, get the book. There's a nice book. That's what someone told me. And then they disappear. If you came in for the 4th ANC visit, we'll do a simple urine test and we'll know whether you have the hypertension, which is a leading cause of death. For us in Bungoma County, it precipitates a lot of premature births or deaths. So if we could just do that simple urine test, then we will know you're a case that we need to watch more closely. And you'll be told, ma'am, we would like you to come in a little bit more because you're complicated. So I think for me, it is little things, and like she said, let the lower facilities work, but I think for me also, let the level 4s truly work, so that when you're referred from a dispensary, you're not traveling so far to get to the county referral when there's a sub-county hospital that could actually take care of your problem.
All right. Milcah, very quickly, the aftercare, how do we go about taking care of a patient that has just gotten surgery? What is the role that even the people around her can be able to give us part of support?
Okay, after the client has gone through surgery, the surgeon, while still in theatre, tries to confirm that the leakage is not there. There's a dye that is used to check if the leakage is happening. That is the dye that we use even for screening. So immediately before the client is brought out of theatre, the surgeon tries to confirm that the leakage has stopped, and then for a VVF, they are left with a catheter. The catheter is a tube that drains urine from the bladder, so that this bladder doesn't get so full and like the suture line gives way. Also to give it time to heal. So for clients who have leaking urine, that is VVF, they have to stay with this catheter for a bit long, so that the healing process takes place. So once the client goes back to the ward, they're encouraged to drink a lot of water, so that this is a patient who was naturally dehydrated, because they fear even drinking water before. Because the more they drink, the more the urine flows. So naturally you'll find that most of our VVF clients are usually very dehydrated. So as they heal, we encourage them to take plenty of water to rehydrate, and also to just open up the kidneys and get back to to the usual normal functioning.
Okay.
So this woman will be given antibiotics, they'll be given painkillers while still in the ward, just to manage the post-op issues, the infection and the pain. And some of them will even get discharged with the catheter. They get checked after 2 weeks, after 4 weeks, depending on how the surgery went on and depending on how the how severe the case was.
Okay.
So they continue with the healing process slowly, and the other issue that usually gets to them is how to get back into the society.
To the home.
Yeah, as in, these people had sidelined her, people had stigmatized her. How does she get back to her feet? How does she get to integrate and get back into the society as a normal woman? Yeah.
All right. And thank you so much. At least now we know that fistula is preventable, but it is also treatable.
Sure.
It is very treatable.
It
so
is treatable.
there is no need for somebody to suffer for so many years because of something that can be corrected. And you can go on living your life as you used to before it happened. Thank you so much for that. I'll come back to you, Caroline. What should people of Bungoma expect from you going forward?
Definitely another fistula camp very soon.
Many more to
because
come.
the phone calls are coming in. Actually, what I'm very happy about is what that camp did is it demystified the subject. And we're having calls coming in and people are asking. Yesterday I was being asked, when are you doing another camp? And I had to call Milcah and ask, when are you coming to do another camp? So it's a discussion we're having. I think one of the things that I want to do is to really raise up the issues in health. And I'm going to do that through medical camps. So I'm likely to do 4 general medical camps in a year and rotate them across the sub-counties. I'm likely, with the help of wonderful people like AMREF, to do some specialist camps. I'm hoping we can keep doing the fistula camps until we mop out the population. When you listen to what she said, with our 2014 percentage of 41% for skilled delivery, if we've been having 59% of our mothers giving birth at home, there's a good chance we have a pool of mothers that are suffering quietly. So I would like to mop those ones out in the next 4 years with the help of these wonderful people. I also would like, because we have a border we have a border economy that's very strong, and it's also brought along a lot of accidents. I'm hoping to still talk to the very AMREF
to come back and
to come and do a specialist orthopedic camp, because
about that.
a lot of our people have had injuries, and we just like to support them. But even as we do this, one of the things also is to put a voice of advocacy to the governor, such that, you know, as they do their budgets, as they think about where to prioritize health, I'm hoping with the activities that I do, I'm able to inform them that you probably need to give a bit of a focus here. Even when you're resourcing, you see, like, we have only 1 gynecologist in our county. Against an expected
the whole
birth
of Bungoma County.
That is right. Against, you know, 66,000 women are expected to give birth this year. So we're able to expose the gap to the governor and tell him, you know, when you're thinking of resourcing, you might want to prioritize maybe a gynecologist. We have 1 pediatrician for the whole county again, all these lovely babies. And we have a very poor neonatal indicator. We're probably one of the counties that has the highest neonatal mortality indicator. So what I hope I will be able to do is to literally bring to the fore the problems and allow the decision makers to be able to come up with a strategy to address these problems, because you cannot address what you don't know.
Yeah, that's true.
And I feel that's a role our office can easily play. I'm also very interested in the sickle cell space. Sickle cell is a disease that has been forgotten. 17 counties in this country have sickle cell. It's endemic in those counties. In our county, it's a heavy burden, and it affects both the maternal and neonatal mortalities. So it is something that I'm working on very closely. We're working very closely with the University of Nairobi to bring a comprehensive care program to the people and try to manage it, because much as we talk about malaria, we still have mortalities that are being